Hi, I'm Tim Wiedrich, Section Chief for the Health Resources and Response Section with the North Dakota Department of Health. Tim Blasel is not able to be with us today, so we're going to head straight on into the first topic, which is the hospital intelligence update, and Grace Najou is with us to deliver that report. Grace? Grace is not with us yet, and so let's go ahead and move on to the next item, and we'll come back to Grace in just a moment. Let me see if Dr. Connell is with us. Dr. Connell, are you here? I see you. And so,
Hi, sorry, I just popped in from clinic.
Sure. So I just wanted us to have some conversation about the monoclonal antibody treatments, and just if you let me set the stage just for a moment. We have some new processes that are rapidly evolving, and so I want to kind of come back to a central theme, and the theme is that if you need to have any of the pharmaceuticals associated with the infusion treatments, please contact the Department Operations Center. And that number is 701-328-0707, 701-328-0707. If you don't have it and you need it, if you think you need it because of something that's happening within your area, maybe a very high positivity rate, it just doesn't matter. Give us a call, and we will be able to quickly move that product to you. I know that, just to start to set the stage a little bit, that right now we're on an every other week allocation process, and very recently now we've been informed that there's a way to call in between those 2-week increments and order additional product from the federal government. And just today we learned that there's a new process for long-term care where they're going to begin to be delivered product directly from the federal government through their pharmacies, and there may be other mechanisms that are coming into play, and that is pretty complex in that there are about 4 or 5 different organizations for the direct distribution from the federal government to the long-term care pharmacies. So if you remember nothing else, remember the phone number 701-328-0707, and we will get product to you. And the rest of it we can get squared away and straightened out to help you maneuver the rest of it on an ongoing basis. But now, having set that foundation, Dr. Connell, could you add some additional comments in terms of where you see this program at and any of the other issues you'd like to talk about?
Sure. Well, I think what's really exciting is the program seems to be really taking off. And, I think I shared with this group last week that at this point, since we've had access to monoclonal antibody for several weeks now, if we have patients who meet the risk criteria, who did not receive monoclonal antibody therapy and are being hospitalized or dying from COVID, that really we need to start taking some of that responsibility for not providing the patients what they're needing. So if that's going to be our goal, we really need to make sure that that's accessible. So just to review some of the major things that have occurred to increase accessibility and knowledge about these medications that can be life-saving and even decrease the morbidity associated with COVID-19. We have developed processes by which long-term care facilities are being notified when they have a positive patient, since being 65 and over is one of the categories that make you high risk. And Seth Fisher and his group are counseling those long-term care facilities about the use of monoclonal antibodies in their positive patients. We've also been on a couple of press conferences now to try and spread the word to patients, their loved ones, and providers. And there's going to be some additional education that's provided. In creating that spreadsheet that contains all of the facilities that we're aware of who are utilizing monoclonal antibody therapy, we have been able to help those facilities break through some barriers, and also by sharing that spreadsheet with others, including Long-Term Care Association and the Federally Qualified Health Center group, make others aware of their potential local access to therapy. And then we've helped other institutions get the ball rolling to utilize monoclonal antibody therapy in their facilities. So by providing the medication as well as helping to provide some order templates to make it easier to get their programs up and running. And honestly, I expect to do more of that individual facility, helping understand what the barriers are and help them break through them when possible, more next week. So I'll be excited to share that with you. So again, I think a lot's happening with this. I heard that in the first 5 weeks we had monoclonal antibody therapy, 500 doses were given, and last week 700 doses were given in 1 week's time. So we've dramatically increased access to the medication. And we need to continue to do that to decrease morbidity and mortality associated with COVID in these high-risk groups. So if you guys have any additional questions, you can certainly ask me at the end of this program, or you can email me or give me a call. And I'm happy to discuss this with you and happy to work through any barriers you might have to see if we can make this work at your institutions. Thank you.
All right. Thanks, Dr. Connell. Well, let's head back to Grace and find out information about the hospital intelligence update. Grace?
I forgot that you start promptly exactly at 2 p.m. So my apologies, I was running just 1 minute late, but I will try and share my screen. You confirm that you can see that?
Not with us yet, but I just saw it flash in and now we have it.
Okay, perfect. So I'll just start with like the summary and sort of like the recommendations that we passed on to the governor's office this week. Really, the good news is we are seeing an uptick in the testing. And so overall, compared to the previous week, we did observe about a 5% increase in the number of people getting tested. That is still well below our goal of getting 55,000 tests conducted in a day. In a week, but overall the increase in testing is a bit promising because we were at a bit of a lull there. And this is also confounded by the fact that we're seeing a lower positivity rate. So we did observe a decrease of about 17% in our positivity rate. So again, that continues to reflect that we may be continuing to head in a good direction. And then in terms of new cases, for the last week, we had about 1,284 cases. And again, this was a decrease of about 15% compared to the 1,600 that we had the previous week. And so on Monday, the masking mandate did expire, but I think the message, or at least our recommendation moving forward, is to really continue to, continue mask wearing in public and also in indoor spaces where, social distancing is impossible, and continue with some of the mitigation factors that we had outlined previously, such as the washing your hands, avoiding large gatherings, because as you may all know, with the variants that we're seeing out there, we cannot get too confident or too cocky that we're out of the worst of this COVID situation. In the last week, we did observe a decrease in hospitalizations. We had about 96 the previous week. This week, as of the 16th, I believe actually of the 16th, we had 57, but that spiked up to about 91 active hospitalization. That, if you look on our website today, has gone down to about 55 currently hospitalized individuals in the state. And some of that is due to some data issues, but overall, we do continue to see a declining trend in decreasing hospitalizations. And so some of the big takeaways is really, the vaccine, and I saw Molly on the call, so I'll not get into this, but really continuing with that uptake of the vaccine in healthcare providers and the most vulnerable populations is one of the key ways that we can get out of this. And also the outpatient therapies that keep individuals out of the hospital. Those, I don't know that we can oversell those, just because from what I'm reading in the literature and some of the evidence out there, it just looks like they're really promising in reducing our hospitalization rates. And we all know once you're hospitalized, your risk of mortality does increase. And so rolling those out to our most vulnerable individuals seems like a great strategy. And I'm glad that Dr. Connell is on this. In getting into some of the numbers, so one of the improvements that we've seen this week, so to coincide with our increased testing and lower positivity, our infection rate, which is this effective reproduction number, has decreased to about 0.92. This is as of the 16th, so it is a few days old. But overall, I think this is good news, and it is, again, we want to keep this number below 1. And if we can continue on that trend, that means that the transmission is not happening to more than one person. In terms of counties of interest, so overall, everyone, or at least the majority of the counties, close to 70%, are under that one threshold, which is this value here. But we did observe a few counties that have higher reproduction numbers. Adams County is one of them, Bowman. And overall, if you look at the maps on our website, that southwest region of the state just seems to be having some spikes in the number of cases. And upon further investigation, there were some cases related to some school events, some sports events. And so, like I said, I don't know that we're out of the woods yet, so it's not a time to fully re-engage in some of the social activities that we used to, because that potential for an outbreak can happen, and that seems to be what's happening in that southwest region of the state. Well, and the good news, though, however, is that it does seem to coincide with smaller numbers, just because these are some of the smaller counties in terms of populations. And then in terms of changes by week, so this would be compared to the week of the 10th to the week of the 17th. As I mentioned, we had some issues. I think when I showed this map last week, this was sort of like the hot spot, but it does look like Burke and Pembina counties seem to be on the increase in their reproduction values. And I will touch base with our disease control team to see if there are any known causes that may be contributing to these spikes. But overall, I think the state looks to be in good shape. And I think, as I mentioned, in terms of testing, we have observed an increase in testing, which again is always good, because you really want to be sure that the disease is not lurking in the population. And so compared to this week of the 10th and into the week of the 17th, while this spike may be kind of like falsely deceiving, overall this week we did observe an increased number of tests compared to this week. And what you see in the orange is the PCR test, and the gray are the antigen tests. So over time, what we're seeing is more of the uptake of the antigen tests in the state. I've been sharing this graph just because I think it's very important, because of what we know about the false negativity rate of the antigen tests. We always want to make sure that there is this alignment of the positivity of the PCR test, which is considered to be the gold standard, and the antigen test. And overall, we do continue to see sort of like, it's not a perfect alignment, but compared to the week of I believe this was the week of Christmas, overall, we're seeing more alignment in the positivity rates. And as of the, that's the 17th, the two only differed by about one was 5%, and that was the antigen positivity, and the orange, which is the PCR, was about 3%. And then in terms of the trends in hospitalizations, so overall, I think this table has a lot of information, but I hope it's easy to synthesize. So these are just the months. And then this is the time to diagnose, from diagnosis to hospitalizations, and then the count of hospitalizations per month compared to the number of cases, and then the hospitalization rate, average length of stay, and then this includes the ones who are currently hospitalized. And so what you do see here is over time, we do see, well, I think this might be I'll start with this one. So time from diagnosis to hospitalization, and this is an average. So what we found to be kind of interesting in January, and though, I mean, we're still not over the whole month of January, is the time from diagnosis to being hospitalized has increased, almost doubled compared to December, and that doubled compared to November. And so what we're finding is people are essentially lasting longer from the time they're diagnosed to when they're hospitalized compared to previous months. We have seen a decrease in the number of people hospitalized over time. We did see that peak in October and November. December, we were down to 559, and as of the 17th, we're down to only about 133 cases hospitalized. And this, is while the percent, this is the hospitalization percent, has not really changed much over time. The number of new cases has really decreased, which is what's contributing to a low number of hospitalizations, as you would expect. The other good news is over time, we have seen a decrease in the average length of stay. So this could be a testament to some of the therapeutics being used in the hospitals. And so our patients are not staying longer in the hospital compared to what has happened in previous months. I believe the highest average length of stay was in April, and now it's down to about 4.1 days for our currently hospitalized patients in January. And when you exclude the ones who are currently hospitalized, it actually does go down to about 2 days of hospitalizations for the patients that were diagnosed in January. All right, and then looking at our neighbors, overall the trend of hospitalizations declining continues. And I think we discussed this last week. South Dakota is probably the worst offender in terms of the hospitalization rates. They do have the highest number of individuals currently hospitalized, and they've had pretty much, I think, almost starting in maybe mid-September, they've always had the highest number of people hospitalized per capita. And that was closely followed by North Dakota. But it looks like over time, North Dakota, which is in the yellow, has really had a much steeper decline. We did see a little bit of an increase earlier this week that I pointed to, but I think if we pull these data today, it would pretty much go down to probably be under or at least below Minnesota in terms of the number of people hospitalized per capita. In terms of what could be contributing to some of this, I know we've talked about the outpatient therapies, but I would just like to highlight that this is a graphic from the New York Times, and I know the CDC has a similar version. And I hope I'm not stealing Molly's thunder because this is about vaccines. But I think it's a testament to the whole immunization program and Tim and his team in terms of rolling out the vaccine, because North Dakota has consistently ranked in the top 5 of states that have distributed the largest amount of the doses allocated since this program began. So that's really good news, and it's going to help in terms of keeping our hospitalizations down. This was from a different presentation, but I can certainly talk about it. This is our excess mortality. I think when people ask, is COVID a hoax? I think this is some of the evidence that you can present to your friends. So overall, what you see, this chart is a bit complex, but I will try to explain it simply. So up here, what you see is the different age groups. What you see in the red lines, that's the 2020 death rates, or at least the percent deaths in North Dakota. This is all North Dakota information. And then down here, what you see is the weeks over time. And then what you see here in the color coding is just the percent of excess deaths that were reported in the state over time. So it ranges from about 0 to greater than 500%. I don't know that we hit the 500% mark, but on a few weeks, we did hit that greater than 200% mark of excess deaths compared to what was reported from 2015 through 2019. And so overall, the big takeaway from this chart is you do see excess deaths if you look very closely on each of these charts over time across almost all age groups, starting from the age of 25. And unfortunately, our older adults, as we've discussed in previous presentations, they are some of the people hit the hardest by the COVID pandemic. And really, when you look at, the 4 years preceding 2020 and you look at just 2020, it's pretty obvious that something happened and something drastic happened to increase the proportion of deaths that happened in North Dakota. And then looking ahead, so our projections haven't really changed much. What you see here is our projected cases, which is that blue line compared to our actual, which is the orange line. And basically, based on the information that we had we ran this model on the 17th, we do continue to see a declining trend in cases. And also this certainly coincides with the declining trends in hospitalizations. For a while there, as I've pointed out previously, our model did underestimate the hospitalizations, but this seems to have sort of gone back to just being closely aligned. And same with the deaths. Again, we just anticipate this continuing decline in terms of the projected cases, hospitalizations, and deaths. Tim, I believe that's all I have for today.
All right, thank you very much, Grace. And we'll be back with Grace at the end for questions. But now let's go over to Molly Howell and find out some additional information about the vaccination program. Molly?
Good afternoon, everyone. I did send out an email update this morning, and so all of your COVID vaccine coordinators and backup should have received that. But I did want to, I can provide you with an update as well. In terms of priority groups for vaccination, you may have seen in the media last week that Health and Human Services at the federal level had encouraged states to open up vaccination to everyone 65 and older and those 16 to 64 with underlying health conditions. Because we just don't have that much vaccine, and those would be large population groups. 65 and older is about 116,000 people, 16 to 64 with underlying health conditions. When you include things like obesity and smoking and diabetes, that's well over 100,000 individuals. We didn't really feel like we could do that as a state. And so we are keeping our priority groups that we previously released. And so there have been no changes in North Dakota priority groups or phases for vaccination. Those are still posted on our website. We did do a social media post on that last week and discussed it at the governor's press conference on Friday. So hopefully that cleared some things up. I will say a couple weeks ago, we did tell providers that they could start vaccinating phase 1B. And so many of you may already be vaccinating phase 1B. A lot of that depends on your vaccine supply at a local level. The first group in phase 1B is the 75 and older population. I do want to encourage you, and there actually was an op-ed in the Fargo Forum today. I know a lot of people are using like electronic medical records and charting or online surveys. A lot of people in that population may not be able to use the internet or have access to a computer or may not feel comfortable. And so when you're thinking about vaccinating the 75 and older population, I really encourage you to have hotlines that can assist people with scheduling appointments, or you might have to make phone calls to them or kind of put in some extra effort in order to get them scheduled for doses. And then also we do have some homebound individuals who are 75 and older. And so just a plug to kind of remember those individuals as well. And then just so everyone's aware, you don't need approval to continue on in phase 1B. And so if you've offered vaccine to everyone 75 and older, we want you to just continue right on. We don't want vaccine to be sitting in your freezer or refrigerator. So then call in people who are 65 and older with underlying health conditions and keep on moving down the priority list, as we don't want there to be any vaccines sitting. Hopefully all of you are thinking about it similar probably to monoclonal antibodies, that if it's just sitting there unused, it's not doing any good. And that's a potential life that could be saved. And so we want the vaccine going into arms. Ideally, we want providers giving doses the same week that they receive them from us or from the federal government. Last week, we did set up a COVID vaccine locator on our website in the hopes that that would help the public try and find vaccine. It's also helping our hotline work with a number of people trying to find vaccine in their areas. And so I encourage you to make sure that that's up to date. Providers actually populate that based on what priority group you're vaccinating in, and then also whatever instructions you want it to say to your patients. Also last week, there was some information in the media about allocations of vaccine from the federal government being increased due to the Fed starting to release second doses at the same time as first doses. After that announcement, we were informed that there is not a reserve of second doses at the federal government, that they have been shipping out doses as soon as they're manufactured and approved for release. And so we are not anticipating an increase in vaccine. We won't be receiving second doses at the same time as first doses. So our allocation really is staying below 10,000 first doses each week is what North Dakota is being allocated. And then you will get second doses on top of those first doses later on when it's time. So 3 weeks after you receive Pfizer, 4 weeks after you receive the Moderna vaccine. But just to let you know, I think there was some impression last week that there was going to be a large amount of vaccine released from the federal government, and we've been informed that that's not the case. For phase 1B, we are allocating to providers based on the county population for 65 and older. And then we're divvying up doses by provider site based on size and then historical flu doses administered. We do have almost 400 healthcare providers across the state enrolled to receive and administer COVID vaccine. And so to avoid spreading less than 10,000 doses across 400 different providers, and then also we have a warehouse who is working extremely hard repackaging vaccine, but I don't want to have them do that 400 times every week. We are putting providers on a rotation by provider type for vaccine. And so, for example, this week, hospital clinics or health system associated clinics are receiving COVID-19 vaccine. Next week, local public health and tribal health are receiving COVID vaccine. And then the following week, pharmacies and independent clinics are receiving COVID-19 vaccine. And so until we have more doses, we're going to keep provider sites on that 3-week rotation, and you'll just be rotating each week. And we're hoping to have allocations to you a couple weeks ahead of time, so then you can do some planning around how many doses you're going to receive. We did receive word today that Pfizer is going to start allocating to us, and they're taking into consideration the 6th dose that's been able to be extracted from the vial. And so now they're saying instead of 975 doses in a Pfizer tray, it's 1,170 doses. So it might look like our allocation is going up after next week, but really we're receiving the same number of doses. They're just reflecting the extra dose that people have been able to receive out of the Pfizer vial. And also providers are receiving extra doses out of the Moderna vial, and you can use those extra doses as well. But I haven't heard of a change in how the Moderna vaccine will be allocated to us or the quantities. Otherwise, I think for the most part, we have a dashboard on our website. And so every day we update how many doses have been administered versus how many have been received. North Dakota healthcare providers are doing an awesome job administering doses as soon as you receive them. I encourage you to continue doing that. There was some indication at the federal level that they may allocate to states based on the pace of administration. And so if that's the case, it might positively impact North Dakota's allocations. I don't know that for sure with the new president coming into office. So we'll have to see if that remains the same. And then just a plug to that people really do need 2 doses. And so we still recommend that people get first and second doses. You shouldn't just be giving everybody first doses. And then otherwise, I think that's all I had to update. I unfortunately have to hop to another meeting, but if anyone ever has questions, we have an email inbox that gets answered the same day, covidvaccine@nd.gov, and we can get all your questions answered about COVID vaccine.
Great. Thank you, Molly. Well, data has been an extremely important part of this response, and hospital data is extremely high on that priority list. And so thank you to everyone that has been submitting data. Cody Pinks has been assisting with that process, and let's turn to Cody now and see what additional information Cody may have.
Thank you for having me. So as of last night, and so this morning, there are 7 new vaccine administration questions that were added into HC Standard for the hospitals to report on. It can be found right after the therapeutics tab across the top when you're in HC Standard. These questions only have to be reported on once a week on Wednesdays. It is not required by HHS, so it's not one of the mandatory questions that they require, but it is information that the state needs. So I'm asking everyone to please fill those in. On top of that, I've received several questions this morning that I thought would help if I address them through this meeting. So one of them that I received quite a bit of questions on is questions 46 and 47, which asked about patients getting vaccinated. And so quite a few hospitals wanted to know what is considered a patient. Is it just those that are hospitalized? Is it outpatients? And my response when I asked HHS for clarification is that it is any patient that is vaccinated by the facility, whether inpatient or outpatient. So it's not just inpatient like most of our other questions are. If your facility does not provide COVID vaccines to staff or patients, make sure you don't leave questions blank. It's just a good habit to get into so those don't count against you, because I have a feeling at some point these could be required questions. Make sure to put in zeros if that does. I don't know if the option is non-applicable is available, but if not, enter 0. And then let's see here in my notes. Okay, so as of, I just recently received this information. We've had 42 out of the 51 hospitals report these questions so far, and that was probably around 2 o'clock. So for the few that haven't yet, please enter in this information. I know a few hospitals had some issues or concerns about reporting these vaccination questions. So if there's anything in particular, get a hold of me and we'll talk through it. Other than that, that's all I have, Tim.
Thank you so much, Cody. Let's check in now with the Health Research and Response section and see if we have anyone that's with us today to talk about testing. Is anyone with us from Health Resources and Health Research and Response? Not seeing any. Let's turn our attention now to the PPE supply and check in with Angie Strand.
Good afternoon. Thank you, Tim. So we're slowly but surely getting deliveries of the items we've put in orders or put in POs for purchase orders in when it comes to PPE, and the cash does look good at this time. But just due to the uncertainty of the response, we can't get complacent. So we continue to look for PPE, vet vendors and supplies to ensure that we can sustain and be able to supply to those in need in the health, medical, and first responder communities. So we'll go ahead and start off with the N95s. We're sitting at over 1 million, so 1,051,700. So those are looking good, with 443,900 of those being the most fit tested 3M N95 1860 model for the N95s. And there were 6,700 issued within the last week. Moving on to surgical masks, there are 2.8 million, and there were 7,800 issued during the last week. Shoe coverings, they're not a very popular item when it comes to requests, but we want to ensure that we have those available, and we're at 20,786. For gowns, we're at 1.1 million, and there were 850 issued within this last week. For gloves, we're at 1.9 million, and there were 25,000 issued within this last week. So yes, again, those are one of the most requested items at this time. Face shields are at 634,492. There were 360 issued last week. And goggles, there weren't any requests, so the numbers remain the same as last week, so 22,452. We did receive a delivery that we put in a few months ago for 5,000 individual pairs of goggles. So the numbers stay the same when it came to the requests coming in, but they did bump up due to the inventory being added to. And that concludes my portion of the briefing. Unless there's questions, I'll be available at the end of the meeting. Thanks, Tim.
Thanks, Angie. And that also brings to the end of the information we had to bring to you. The VP3 team is on with us, but they've been very busy, diligently working, but have no updates for today. And so let's turn now to the hospital reports and see if you have anything that you want to share, any questions that you want to ask. If you do, just go ahead and unmute your microphone. And we're just going to go ahead and deal with it that way rather than going in a round-robin affair. So if you have any questions or comments for either the presenters or other hospitals, just go ahead and unmute your microphone and state your question or your comment.
Tim, this is Marianne Doling from Carrington, and I had a message in the chat. We had medical staff earlier today, and they were questioning if anything has changed with a patient who's had COVID in the last 90 days about testing for that patient for any reason for pre-surgery. You know, they're down for surgery now and it's been 90 days. What's the newest guidance, if any, on that?
Let me see if anyone from disease control or Dr. Connell want to tackle that question. So I'll go ahead and tackle it. I am not aware that there have been any changes that have been made to the testing process pre-surgery, and but I will, Marianne, we're going to reach back to you with that specific piece of information and give you absolute confirmation of that.
Thank you. And then just keep in mind it's for the patients that have had COVID already.
Thank you for clarifying that.
Tim, it's my understanding too that if you have had COVID, you don't need to be tested for 90 days from the point of diagnosis, unless you are symptomatic with symptoms that could be potentially consistent with COVID. And if that's the case, providers are encouraged to rule out all of the other things on the differential diagnosis. And then if you've ruled everything else out at that point, consider a diagnosis of COVID. So for routine pre-op testing, you would not do that for 90 days post-COVID diagnosis.
Thank you.
Thank you. Thanks, Dr. Connell. Thanks, Marianne. All right. Any other questions or comments?
Eric Christensen from Rugby's Hospital. Just a question. So you're saying that vaccine allocations to hospitals and clinics attached to hospitals will be every 3 weeks now. I just want to clarify that as I do messaging out to the public here in Rugby.
So does anybody from disease control or George want to comment on that? And if not, I will.
So when we see the shark-based appearance, we can call it bronchospasm, we can call it shark fin, we can call it obstruction.
George, I'm seeing you, but I think that you're muted. Go ahead and unmute, please.
Definition is evidence of uneven.
Can you hear me now?
Now I can hear you.
Okay. Yes, my understanding is that the allocations will be on a rolling 3-week rotation. It'll give you a larger number of allocations and give you more time to get out there and get those second doses administered where needed, and get that medication out where it is. So that is the plan right now, is my understanding. So that it'll be, and I don't remember what the other 2 weeks are, but yeah, it'll be on a rolling 3-week, and like I said, it gives you a larger allocation, and it'll get be able to do more and get more of your population covered.
And even on our lab with the hospital, continue to have uneven alveoli.
Thanks, Eric. Thanks, George. Other questions or comments?
Just a follow-up to that, do we need to send in a request for the amount of vaccine we would like as a hospital?
George?
Based on the allocation, I got a background. Hold on 1 second. Something's running. Sorry. Hold on.
We were previously trying to intubate or intubate and treat force.
There. I don't know where that came from. Sorry about that. No, the way I understand it is when the allocation comes out, they will divide it up based on their numbers that they have. And then they should be sending an email out to the point of contact earlier in the week. And then saying, this is what your allocation is for the week. And then it'll come back. And then you respond back to that. And then from there, they order that yes or no. If you want a lesser amount or whatever, then they would put that in the system, allocate it, get it ordered on Friday. And then we at the warehouse, if it has to come to us, it'll come to the warehouse on Monday. Usually on Monday. Otherwise, your allocation will be direct delivered on that Monday to you if you have a large enough size to get direct deliver. Otherwise, if it's delivered to the warehouse, we'll split it up on Monday, get it broken down into where it needs to go, and then usually on Tuesday, we try to get it out on Tuesday and delivered. That'll give us Wednesday to pick up any slack if we need to, and then on Thursday the second rounds come in for the previous 2 or 3 weeks ago, and then we deliver those on Friday and Monday, and then we turn around and do it all over again. So
Did that answer your question?
Yes, it did.
Great, thank you. Other questions or comments?
Tim, this is Ricky from Jamestown. Just a couple questions on the hospital intelligence update, I think from Grace. In her slides, has the trending been updated based on the adjustments that were made due to some errors earlier, late in December, maybe early January? Are those contained in those slides?
Grace?
So are you speaking about the projections or the actual values?
I would say probably actual, Grace.
So the slides were actually made on the 17th, and I believe the update was made today because that's when we made some of that correction. And so the actual may not be accurate, but for next week, I'll be sure to clarify the
Just trying to
include the most recent update.
Thank you. I just was trying to follow those trends, and based on some of the information, it looked like maybe that hadn't been modified for those with those updates. And then can I ask a follow-up question, Tim?
Absolutely, but I'm really impressed that with the level of detail that you looked at that data. So way to go.
I am so happy to see that data trending the way that it is.
We all are.
Yes. Point taken. A quick question on PPE. I think I heard maybe last week, Tim, that you were giving us a little bit of grace and forgiveness of if we've received supply from the state that we won't have to replenish. Just wanted to confirm if I heard that correct.
So I think that the short answer is yes. We won't know until we're at the way end of this. And so we started, and I like to use the example of the N95 respirators. We started with 1.4 million N95 respirators. It took us about a decade to build up that amount based on the grant funding that we had. And so we were sitting very strong, in my opinion, for PPE. And so what I want to do is continue to monitor until we get to the very end of this process. And once all the CARES funding and all the other funding sources have stopped, if we have not exhausted what we have in the medical cash, and if we've restored it back, and then it's our intention not to ask anybody to replace it. It got replaced, and we'll be in good shape at that point. But with all these other potential anomalies that are happening with other strains that are developing and so forth, we just haven't seen the last chapter yet. And so I'm very optimistic at this point that we're not going to need to ask to replenish. And if somebody's in a financial condition where they simply can't do it, well, obviously we're not going to place that type of strain on anybody. But we do want to emerge at the end of this with a medical cache intact so that we're ready for whatever the future may bring. So thank you for the question and the opportunity to give you a rather lengthy response.
Thank you. And just one more time, I thank you guys immensely for taking the time to have these calls.
Well, thank you for your participation. This really helps in terms of getting information out and hearing back from you as well. So this is mutually beneficial, all part of the same team. All right, other questions or comments? Well, it looks like we've exhausted them for today, and so we'll be back again next week. Remember that we do this every every Wednesday at 2 o'clock, and we have the archived versions of this on our website at www.ndhealth.gov/AT. Take care, everybody.